Now, is another discussion today about cardiovascular and dynamics in terms of the blood. And previously, we talked about edema. Then today, we'll talk about shock. Remember very well that blood pressure is controlled by various things like cardiac output, peripheral resistance, stroke volume, all those ones. And these things can be influenced by any other factors. And in your day-to-day life, we have heard people about shock. Somebody was found in shock, or somebody was told some stories and then developed shock, or somebody was bleeding and developed some shock. So let us interrogate and see exactly what happens when somebody talks about shock in our day-to-day discussion, so that we can be able to tackle these things about shock. So by definition, shock is a state of poor perfusion in impaired metabolism manifested with severe pathophysiological and abnormalities. That is when the tissues and the cells of the body have impaired or improper blood supply, which results now to metabolism shifting from aerobic respiration to anaerobic respiration. This is due to circulatory collapse and the tissue hypoxia. So before that one, let us look at our body components in terms of water, because water is the greatest carrier of blood and the blood is the greatest carrier of oxygen. So we have to get the basic understanding of the amount of water in our body. So in a normal person who is 70 kgs, we assume somebody is a normal adult person is 70 kgs. So we say that 0.6% of your body is water. 0.6% of your body is water. So assuming that this somebody is having a 70%, 70 kgs, that means this person is having 42 liters of body water in total, because 0.6 is the water in the body. So this person is having 42 liters of body. So in this 42 liters, we are advanced of the blood is intracellular. That means the blood is inside the cell, which is equivalent to that 14 liters. Whereas 2/3 of the blood of the water is extracellular, outside the cell, and this is equivalent to 28 liters of water. You see that now that a more amount of water in our body is outside the cell, and a few amount of water is inside the cell, and it is separated by the cell membrane, which allows infusion water to come in and out of the water, out of the cell, but that is in our homeostatic state. Now, in this intracellular water, again, it is divided into two other things. That is the capillaries. The interstitial fluid contains 10.5 liters, whereas the capillaries and the plasma contains 3.5 liters of water. And these ones is separated by capillary wall. So the plasma is 3.5, and you know the plasma is the one is in the capillaries, which carries various things like cells, the food, oxygen, and the glucose to various parts of the body. So out of this one now, you have seen the amount of water at various stages in our body, the amount of water in our body, the amount of water in the cells outside the cells, and the intracellular and extracellular, all those ones, you have seen them. Now let us see the forces which control the amount of water or the pulling circulation of water in the body. For example, you will see that there's something called steering forces, which these are the forces which ensures there is a blood flow inside the blood vessels, and the minute blood vessel is called a capillary. Which maintains the homeostasis. The normal equilibrium of fluid in our body is maintained by these forces. Now we have the force called capillary hydrostatic pressure, and then this pressure is the one which is between the wall of the capillaries, which controls the wall of the capillary to the outer. Then we have the interstitial fluid hydrostatic pressure. That is the tissues pressure exerted by the tissue but to the capillary. Then you have the osmotic force. That is the diffusion force in between the capillaries. That is the cell, the intent and the absorption. Then you have the osmotic forces due to interstitial fluid protein concentration. This one is another force now which moves out of the blood water from the capillaries to the outside. And these factors are also influenced by whether it is the flow of the blood from which side the other side, because you remember that the blood flows from the arterial to the capillary end, arterial to the venous end. So these forces has to play a big role in that. Now, let us look at factors which contribute to causes of shock. There are various things which contribute to shock, and an example of it is hypovolemic shock. An example, hypovolemic shock is associated to reduced in the blood volume, total volume, and this can be because of hemorrhage, for example, in accidents, either from an external wound or fracture, or from an internal like a spleen, liver, or mesenteric, or even a rupture of various organs like even esophagus, a rupture of the intestines, or internal blood vessels, and also even like in the circles of which the blood vessel can rupture and cause internal bleeding. Now, we can also have a severe burns because this one can cause a loss of plasma, and then you can have things like peritonitis, intestinal obstruction, and vomiting and diarrhea of any cause. Then the other one is cardiac cause. The second one is cardiac cause. This one can be associated due to myocardial infarction or acute carditis or acute pulmonary embolism, or can also be because of drug-induced toxemia of any cause or cardiac surgical conditions like valvular heart disease and congenital heart disease. All these ones are conditions which are still the heart resulting to shock. Then we have another one called cardiac compression causes like cardiac tamponade due to correction of blood pass through the pericardial space, which prevents the heart to expand, leading to shock. Then you have trauma to the heart also can cause the problem. Then you have septic shock is due to bacterial infection which releases toxins to the circulations, either endotoxins or exotoxins. Then we have a neurogenic shock, which is due to a sudden anxious or painful sudden stimuli or causing severe splenic vessels vasodilatations. Here, the patient either goes to a cardiac arrest and dies or recovers fully spontaneously, or even sometimes spinal cord injuries or anesthesia can cause a neurogenic shock. So another one is anaphylactic shock is due to type 1 sensitivity reactions. And the other one is because of respiratory causes like atelectasis, that is there is collapse of the lungs, thoracic injuries, tension of pneumothorax, and anesthetic complications. So the other causes we have like adrenal insufficiency, like Addison's disease, and also myxoedema. So now let us look at the pathophysiology of shock. Shock can be only caused, as you have seen up there, either cardiogenic or either neurogenic shock or cardiac shock. All those ones can cause shock, and this one results to reduced cardiac output, and the reduced cardiac output results to vasoconstriction occurs as a compensation to perfusion vital organs like brain, heart, muscles, kidneys, and the liver. And this one results to because of vasoconstriction, it results to tachycardia. In this case, there is a dynamic circulation increases and results to tachypnea occurs to increase due to increased oxygen saturation. This results to peripheral veins, and you remember that the peripheral veins, like the veins, the blood vessels around the calf muscles, they act as capacities, or we call them stars in another one. So in this case, the vessels constrict, diverting blood from splenic and towards the essential organs. So there is decreased blood flow, resulting to reduced glomerular filtration into there, resulting to reduced urine output. This one is a compensatory mechanism because the kidney wants to increase the amount of water in the body, reducing the loss of water through the urine. This one activates the renin angiotensin mechanism, which get activated, resulting to further vasoconstriction and results to androsten's release. The androsten's release is a very important one because it is the major regulator of fluid and salt in our body. Then this one causes salt and water retention, resulting to antidiuretic hormone release, which results to further concentration of the urine occurs. So when the shock persists, cardiac output falls further, resulting to hypertension and tachypnea. Tachycardia occurs leading to poor function of coronary arteries, and in this case now the patient has started developing ischemic heart disease. This one results to hypoxia and metabolism acidosis in the and use of cardiac depressants, resulting to cardiac pump failure. So hypoxia in this case now results to anaerobic metabolism. Now the body, when there is not enough oxygen, now is received from aerobic respiration to anaerobic metabolism, and the byproduct of anaerobic metabolism in lactic is lactic acidosis because of lactic acid. Then is these lactic acid result to destruction of the cell wall, resulting to sodium and calcium entry to the cell is interfered with, resulting to what? Sodium entering the cell, resulting to potassium leaking out of the cell, which causes hyperkalemia, resulting to hyperkalemia and hyponatremia and hypocalcemia. In this case, the intracellular lysosomal breaks down release powerful enzyme which destroys the whole cells. That means now the cells start now destroying itself. For example, a case like sickle cell syndrome occurs, resulting to platelet activated forming small clot in the many places. That means the intrinsic pathway of coagulation is interfered with. This results to disseminated intravascular coagulations, and this one consumption and coagulate further leading to bleeding. So let us look briefly the auto-regulation of glomerular filtration rates, because you know that we have said that the renin system is the major one which regulates the fluid in the body by that androstenedione hormone, because of sodium and water reabsorption in the body. So under normal condition, mean atrial pressure is 80 to 180 millimeters per mercury, and the renal regulation maintains near constant glomerular filtration rate because of the kidney. So you remember that the afferent arteries are wider, whereas the efferent are smaller, so that the blood can create a force inside the glomeruli so that the filtration can take place. That is normal passion. So in myogenic mechanism, the blood pressure increases, resulting to reduced glomerular filtration rate. This in this case of autoregulations. Then there's reabsorption also increases. So there is something called a Ripley's law, where the vessel wall tension, which is equivalent to distancing pressure times radius of the blood vessel in this glomerular area. And when the atrial pressure rises, results to afferent atriostasis, resulting to vascular smooth muscles contraction, resulting to atrial-resistant offset pressure increases, resistant offset, and then increases reabsorption, and then results to glomerular filtration rate remain constant, and vice versa can take place. Now, in a glomerular filtration rate, when the mean atrial pressure is between 80 to 160, they did not auto-regulate at that point. So let us, we have talked about the renin angiotensin system as a way of regulation of the fluid in our body. So let's briefly look at it, and it works like this. If there is shock, there is reduced perfusion of the linus. This one, or if there is reduced sodium, there is activation of the injectoglomerular apparatus, considered as volume receptors. Then there is release of renin. which the major function of renin is to convert angiotensin to angiotensin 1. So angiotensin 1 is converted, works on angiotensin 3, 2 to convert it to angiotensin 3. Then this one, angiotensin is a powerful vasoconstrictor. So there is vasoconstriction in the whole body, resulting to increased platelet resistance, raising the pressure, and then the fluid flows to the kidneys. Then angiotensin 3 is a powerful vasoconstrictor, and then it works on the corticosteroids and then leads to androstenedione. And remember that the androstenedione is the main regulator of sodium and water retention in our body. So in cerebral circulations, autoregulations, if there is shock, there is arterial blood flow and volume is controlled by the autoregulated process, and there is a cerebral arteries constrict when systemic blood pressure rises or when the oxygen increases and carbon dioxide increases and decrease in oxygen. So cerebral arteries dilate when systemic blood pressure falls or when the oxygen increases and carbon dioxide increases. The brain has the ability to maintain constant blood flow with arterial pressure between 60 and 150 mean arterial pressure. That is the normal in the brain. And remember that in the kidney it is 80 to 160. So cerebral blood flow is equal to cerebral perfusion pressure stroke cerebral vascular resistance. Now, that is the blood flowing in the circle of Willis. So, CCP, that is cerebral pressure, perfusion pressure, is the difference between mean arterial pressure and intracranial pressure. And it has to be maintained at equilibrium because it can manifest in intracranial pressure, resulting to defect in the highs and also affecting the problem in the meninges. So what are the effects of shock? Let us look the effect of shock on the heart. So in the heart, there is reduced perfusion resulting to low venous return, decreased cardiac output resulting to hypertension, and hypertension results to tachycardia. Persistent shock causes hypoxia and release of myocardial depression, leading to further cardiac damage. So in the lungs, there is interstitial edema resulting to decreased gaseous exchange, resulting to pulmonary arteriovenous shunting, which results to tachypnea and results to adult acute respiratory distress syndrome and pulmonary edema. In the metabolic pathways, the shock leads to hypoxia, which activates anaerobic metabolism, resulting to lactic acidosis, and lactic acidosis destroys the cell membrane. And when it destroys the cell membrane, the enters the cell, the potassium comes out, and resulting to hyperkalemia and low hyponatremia and hypocalcemia. So antidiuretic hormone is released, which increases the reabsorption of water from renal tubules. Other hormones releases are ACTH, that is corticosteroids hormones, and prostaglandins, histamines, bradykinin, and testosterone to compensate the effect of shock. Again, these hormones plays part autocoins, and there are some of these like prostaglandins, histamines, and bradykinin act, and testosterone act as autocoins, which also works in places of acute inflammation. And they have something in common. They causes smooth muscles constructions, and also they causes vasodilatation. So this one increases, in this case now we are interested in the vasodilatation because they increases the perfusion of the vital organs like the brain, the lungs, and the heart. So in the cellular changes during a shock, there is release of by the cells, they have lysosomal enzymes, we call them hydrolytic enzymes, which alter the cell membrane and permeability, causing cell death and like sickle cell syndrome. So in the brain, then we have sympathetic overactivity, alter the microcirculation, leading to the collapse of the dysfunction. And then there in the brain perfusion, when decreased, the patient becomes drowsy. Brain is the last organ to get underperfusion in all cases because it is the regulator of everything in our body. So in the kidney, the glomerular filtration rate decreases and the tubular reabsorption of salt and water increases for compensatory response. But in severe cases, tubular necrosis set in leading to reversible renal damage when the tubular necrosis occurs. So, the alteration in cellular components, including platelets, leading to disseminated intravascular coagulation, it causes bleeding from all organs of the body because the coagulation, the intrinsic pathway of coagulation is interfered with. Then in the GIT, there is ischemic changes resulting to GIT bleeding, and this patient now starts manifesting with vomiting blood and also blood in stool. Which is aggravated by disseminated intravascular coagulation, and there's also hepatic ischemic leading to increased enzyme level. Then let us look at types of shock. There's vasovagal shock and neurogenic shock. The first, the neurogenic and vasovagal shock, it is sudden dilatation of the peripheral and splenic vessels causing reduced cardiac output and shock, and often may be life-threatening because it causes to a life-threatening condition of hypoxia. So episodes of vasovagal syncope are typically recurrent and usually occur when the predisposing person is exposed to a specific trigger. So prior to losing consciousness, the individual frequently experiences other signs of symptoms such as lightheadedness, nausea, feeling of being extremely hot or cold, accompanied by sweating. So yeah, there is a feeling like tinnitus and also uncomfortable heart or physical thoughts or sometimes confusion or inability to speak or form words, and sometimes associated with melody settling. So there is weakness and visual disturbances such as light seeming to too bright or fuzzy or tunnel vision, and black cloud-like spot in vision, and a feeling of nervousness can occur as well. So the symptoms last for a few seconds before the loss of consciousness, and this which results typical happening when the patient is sitting or standing up. So when when the sufferer passes out, they fall down, and when it is in this position, effective blood flow to the brain is immediately restored, allowing the person to regain consciousness. If the person does not fall into a fully flat spine position and the head remains elevated above the trunk, a state similar to a seizure may result from the blood inability to turn quickly to the brain, and the neurons in the body will fire off and generally cause a muscle to twitch very selectively, but mostly remain very tense. Fainting occurs with a loss of oxygen to the brain. So the cause of vasovagal episodes can be either like a prolonged standing upright for too long, or upright sitting after a duration or limitation, like we call it micturition syncope, or straining chest as to have bowel movement, or during vomiting, standing up very quickly, or static hypotension are the most common cause of vasovagal episodes. Then during our biopsy procedure, stress directly treated to tremor, stress, postural allostatic tachypnea or syndrome, or multiple chronic episodes are experienced daily for many patients due to diagnosis with this syndrome, and episodes are mostly commonly manifested upon standing up. So any painful or unpleasant stimuli such as trauma, or watching or experiencing a medical procedure such as injections, some people can have some shock. Then high pressure or amount or around the chest area after heavy exercise, or severe menstrual cramps, or sensitivity to pain, or arousal of stimuli, example sexy, tickling, or adrenal can cause this type of problem. So sudden onset of extreme emotions like lack of sleep, anger, coughing, being exposed to high temperatures, or normal onset of mute nerve and malformation can cause this type of problem. So a treatment is to avoid trigger, exposure-based exercise with therapies if the trigger is more mental or emotional, example a straight blood, or if the trigger is a specific drug, then avoidance of this is the only treatment. Then drinks with electrolytes is also should be avoided. If they experience prodromal warning signs, should be lying down and release their legs or at least lower their end to increase blood flow to the brain. If the individual has a lot of consciousness, then he or she should be laying down with turning sideways, and then you loosen the clothes so that this person can add blood supply and hair. Wearing graded compression stockings may be helpful in this case. So neurogenic shock is usually due to spinal cord injuries, which causes dilatation of splenic vessels. This type can safely be treated with vasoconstriction drugs to bring up the blood pressure. And there will be bradycardia, hypertension, arrhythmias, and a decreased cardiac output in neurogenic shock. So a neurogenic shock hemodynamic phenomena that can occur within that limit of spinal cord injuries at the fifth thoracic, that's T5 or vertebral or above, and can last up to 6 weeks. Can be in response to spinal anesthesia, result in massive vascular only to poor blood vessel in the body. So in this case now, there is a disruption of the sympathetic nervous system resulting to loss of sympathetic tone, and the loss of sympathetic tone can follow two pathways. Can either follow the parasympathetic pathways response system resulting to reduced heart rate, which can cause reduced cardiac output. On the other side, it can result to venous and atrial vasodilatation, resulting to reduced blood pressure, resulting to reduced venous return, reduced stroke volume, reduced cardiac output, which can cause reduced oxygen supply, resulting to reduced tissue perfusion and impaired cellular metabolism. So blood pressure control, oxygen delivery, maintenance of hemodynamics, airways, fluid, and therapies, intravenous method, reduction therapy should be done, and dopamine and all of alpha agonists can be used in this management of shock. So in hypovolemic shock, most common type of is very common because of hemorrhage, like in maternity, in accidents, fractures, hemothorax, all those types. They're on the surgery, liver or portal vein or major vessels, vomiting, diarrhea due to any cause. Burns is the leading cause of these things called hypovolemic shock. The classification of this one hypovolemic shock can be viewed to blood. You can classify it as per the blood loss, class 1, class 2, class 3, class 4. You can, depending on the amount of blood lost, you can classify it as per the blood loss in terms of percentage. Also, you can classify it as per the pass rate per minute. If the patient is having less than 100 pass per minute, that is class 1. If the patient is having 100 to 120, that is class 2. And if the patient is having 110, 120 to 140, that is class 3, and the class 4 is more than 140. So blood pressure and normal in class 1, class 2, and class 3 and 4, there's decreased. Remember, pass rate, you have to check the carotid pass rate. It's the one which talks faster than the brachio or the radial pass. So the respiratory rate also increases in more than 35 in stage 4. And also another one is urine output milliliters per hour. In severe, that is stage 4, the patient does not pass out any urine. And the central nervous system mental status, patient is anxious in stage 1, very anxious in stage 2, and the anxious and confused in stage 3, and also confused and tragic in stage 4. Now, let us look at cardiogenic shock. Cardiogenic shock causes is defined as a circulatory failure caused by the forward flow leading to tissue hypoxia in the setting up in the intravascular volume with the systolic blood pressure of less than 80 milliliters per minute for that more than 30 minutes. So this one can cause cardiac index of 2 to 2.5 liters per minute, and the vascular meters listening pulmonary capillary wedge pressure resulting to more than 15. It is commonly seen in acute myocardial with a mortality of more than 50%. So patients who have cardiogenic shock and they start having a pulmonary capillary pressure of more than 15, they develop a myocardial infarction because there is impaired coronary circulations, causing ischemic in the heart muscles, myocytes, and then this patient will lose them most of the time. So cardiogenic shock, because of myocardial infarction, can occur in most of the 50% of left ventricular wall damage by infarction. It leads to pulmonary edema and severe. That is linked to the backflow problem that is preload and severe hypoxia. Ischemic necrosis of the left ventricular wall causes failure of the pump. You remember that left ventricle is the heart, thereby decreasing the stroke volume, and then the blood supply in the body is affected. So how do you diagnose this one is you do echo, you can do atrial blood gas analysis, cardiac enzymes, you can do PCBW and electrolyte inspection, and magnesemia, common, and the SNC investigations are the ones which are done like that. So in the management, in this one, you have proper oxygenation, you have to do either intubation, ventilation support, cardioversion, pacing, or arrhythmic drugs, correction of electrolyte, and avoiding fluid overload, prevention of pulmonary edema as in soon to be there as the immediate measure. So the drug which can be used is like beta 1 agonist used to raise cardiac output, prevent there is adequate preload and it's a vascular volume. An example is dobutamine. And then also you have dopamine, which is preferred. And sometimes you can be even forced to use both the dopamine and the vitamin, sometimes in cases of severe conditions. So careful judgmental, you have to use epinephrine or norepinephrine and phosphoesteric inhibitors are often needed, and in that case, you have to be very careful. So other cases, you can use anticoagulants and aspirin are given. You can also give thrombolytic agents, and also you can use nitroglycerin because they cause coronary arterial dilatations. You can also use ACE inhibitors are also used in this type of cases of shock. So sometimes the management can involve intra-aortic balloon, may need to be done where a balloon is inserted so that it can assist in dilatations in this dilatation of the blood vessels, which is collapsing. So percutaneous transluminal coronary angioplasty also can be done, and the coronary artery bypass graft or final, and currently the world is working on. There's a lot of discussion about coronary artery bypass grafting in management of this type of problem, or rerouting is more of rerouting. This one it is relieve pain, preserving of the remaining myocardium and its functions, maintaining adequate preload oxygenation, and minimizing sympathetic stimulations. Corrections of electrolytes should be done, should be the priorities. So let us look at cardiac compression shock. It is probably due to pericardial tamponade. Suppose a fluid collects in between the pericardial cavity, which exert pressure on the heart. That means the heart does not have a place where to expand when it is pumping. This can be because of kinking of blood vessel, massive pulmonary embolism or tension of pneumothorax, or air embolism can cause obstruction, which can reduce preload to the heart. So in this case, acute massive pulmonary embolism from thrombus or an air embolism, 50 ml of air obstructing more than 50% of pulmonary vascular lead to severe shock and sudden death. The Tachypnea, hypotension, pulmonary edema, raised geographic pressure, and gallop rhythm are the main feature in this case of cardiac tamponade. That is tachycardia, hypotension, pulmonary edema, raised geographic venous pressure, and gallop rhythm are the main features in this case. So let us look at septic shock. Septic shock may be due to a gram-positive organism like fungal, virus, protozoa. Negative septicemia, gram like can cause endotoxic shock. So let us see in gram-septic and gram-positive septic shock is due to exotoxins by gram-positive bacteria like Clostridium tetani, Pyogenes, Streptococci, Pneumococci. Breed loss or hypotension is common with the normal cardiac output as a cause. Now, in gram-negative septic shock, we have gram-negative bacteria, endotoxemia, and its effect. It's urinary and gastrointestinal and the respiratory foci are very common, and this gram-negative is the most common cause of what we call septic shock. So let us see the pathophysiology of the septic shock. There is toxins, either endotoxins or exotoxins from organisms. And most common one is the Escherichia coli, Klebsiella, Pseudomonas, and Proteus. This one results to inflammation and cellular activation of the macrophages, neutrophils, and the monocytes. These are the cells of acute inflammation resulting to the release of cytokines, free radicals. And the most common cytokines which are used in acute inflammation is interferon gamma, interleukin 6, and interleukin and the interleukin 1. Sometimes even interleukin 8 comes later. So in this case, now the chemotaxis of the cells, and that's the endothelial injuries of and the coagulation cascade start coming in. There is reversible hypodynamic one stage of aseptic shock with the fever, tachycardia, and tachypnea. There is severe circulatory failure with the failure of the lungs. Most common kidney liver with disseminated intravascular coagulation. This results to hypodynamic reversible cold stages of the septic shock can occur in that. Now, in this case, now you see that the septic shock is typically a vasodilata or shock where there is a peripheral vasodilation possible by potential resistant vasodilation. This is due to toxins reduced release of some form of nitric acid synthesis from the vessel wall, which causes sustained prolonged release of high level of nitric oxide. So the magnitude of infection is quantified as a sepsis, which shows fever, tachycardia, and leukocytosis, and severe sepsis, which can show low tissue function in the organ dysfunction, lactic acidosis, and dysfunction of the liver, kidneys, and the lungs. Septic shock with systemic hypotension less than 90 millimeters of mercury is spite adequate fluid therapy. Severe organ dysfunction, acute lung, kidney, liver injuries, and the maldistribution of blood flow and something in microcirculations. So let us see stages of septic shock. There is stage 1, hyperdynamic, that is warm shock, which this stage is reversible stage. The patient is still very still having an inflammatory response and is so present with fever, tachycardia, and tachypnea. So pyrogenic response is still intact. Patients should be treated with proper at this stage based on blood culture, urine culture, depending on the focus of the infection. Higher antibiotic like that generation of cephalosporins can be given, but in this case, it is very good if you can do culture and sensitivity so that you can know the specific causative microorganism. But in some cases, you remember that the shock does not give you time to get the result for culture and sensitivity, so you have to be giving a proper missile like aminoglycosides, mixed therapy for the purpose to prolong life and ensure that it gives you time to get the result of culture and sensitivity. So the underlying cause is treated like draining the pus, laparotomy for peritonitis, etc. Ventilation support in ICU monitoring may prevent the septic to go to the next cold stage of sepsis. So the other one is hypodynamic hypogenic shock. So that is the second stage is now cold septic shock. Here the pyogenic response is lost. Patient is in the compensated shock state. It is reversible with multiple organ dysfunction syndrome, with anuria, respiratory failure, jaundice, cardiac depression, pulmonary edema, hypoxia, dizziness, eventually coma, and death occurs because this is now has gone to a multiple organ dysfunction syndrome. So now the treatment of shock is the correction of fluid and electrolytes by restores blood transfusion, perfusion, very important, and appropriate antibiotics and treat the cause of focus between abscess wounds or these ones, or also you can do pass urine discharge, viral or this one culture, but the culture will take time before you get the result. Then critical care, oxygen, ventilation support, the vitamin, dopamine, noradrenaline to maintain blood pressure and the urine output. So monitoring the patient by pulse oximeter, cardiac status, urine output, atrial blood gas analysis is very important. So short-term high doses steroid therapy to control and protect cell from cell effect of endotoxemia to improve the cardiac and renal functions. So single dose of methamphetamine or dexamethasone, which often may repeat against after 4 hours, is said to be effective in the toxins. And activating C protein prevent the release of inflammatory mediators and show the effect of these mediators on cellular functions. So anaphylactic shock, you give injections like penicillin, anesthetics, things, venom, selfish, may be having antigen which will combine the immunoglobulin A of mast cells and the basophils leading to histamine and large amount of slow releasing substances for anaphylactic, and these ones they causes vasodilatations and smooth muscles constriction, and if they increases vasodilation, that means they cause reduce the peripheral resistance, and that one reduces effect on the cardiac output, the patient and goes into shock. So the pathophysiology of anaphylactic shock is that the signs and symptoms a patient will have like swelling of the conjunctiva, running nose, swelling of the limbs, there is a tongue and the throat, heartbeat and the vasculature faster through heartbeat, low blood pressure, the skin, eyes, you have itchiness, splashing, and pelvic pain. Then on the other side, the central nervous system will have headache, loss of consciousness, confusion, headache, and anxiety. In the respiratory system, the patient will manifest with the sort of breathlessness, wheezing, stridor, hoarseness, pain with swallowing, cough, and in the GIT, the patient will manifest with crampy abdomen, pain, diarrhea, vomiting, and loss of blood control. So the cause, they can cause a bronchospasm, laryngoedema, respiratory distress, and hypotension and shock, and the mortality is 10%. The rashes over the body are commonly observed, and this is an example of a venom from a bee, which can cause this anaphylactic shock. So the treatment is you give restrictive shock, you give bronchospasm, laryngoedema, generalized rashes, and edema, hypotension, and fever pass. The sudden onset of this ones, you have to start working on bronchospasm. You can start doing intubation, correct edema by giving steroids and also giving fluids because of hypotension. So the mortality rate is around 10%, and in this case, you have to give a patient adrenaline IV, micrograms, steroid IV fluid, oxygen food, and you can have food. You can ventilate your patient, and also you can do cardiac massage. Also, you can do defibrillations. So there is the other type of shock, which is called hemorrhagic shock, classified as based on the source of bleeding. There is hemorrhage due to arterial blood vessels or due to venous blood vessel. If there is a bleeding due to arterial blood vessel, it is the blood is bright red in color, spouting like a jet along with the pulse of the patient, because this one is getting blood from the heart. Then the venous is dark red, steady, and continuous flow. Blood may be severe and rapid when bleeding is from femoral vein, jugular vein, or other major veins, varicose veins, portal vein, esophageal varices. So pulmonary artery blood is dark red in color, and pulmonary venous blood is bright red in color. So capillaries bleeding is rapid and bright red. It is often torrential due to continuous oozing. So based on time of bleeding is another classification, because it can be primary at the time of injury, can occur within 24 hours, that is reactionary, or secondary, that's after 14 days after the surgery. So based on the type, can be caused of renewed bleeding that is visible to the external, and then a concealed bleeding. It constitutes internal hemorrhage like liver injury, spleen, femoral, cerebral hemorrhage, and hemothorax. And also sometimes in a maternity, you can have what you call placenta rupture. Then we have initial concealed but later reviewed hemorrhage like immaterial hemoptysis and Mariana. Based on the region of bleeding is acute or chronic. They are in stages of chronic hypoxia. It is corrected by packed cells transfusion, not by whole blood itself. Causes to be treated accordingly. So acute or chronic hemorrhage is more dangerous as the bleeding occurs in an individual who are already hypoxic, which may get worse faster in already compromised patient. So what are the clinical features of hemorrhagic shock? Patient is pale, dusty, cyanosis, tachycardia, tachypnea, and looking for air. There's cold cramps skin due to vasoconstriction. So dry face, dry mouth, loose skin appearance due to contraction of erector pylorus, rapid pass hypotension or urea. Features related to specific cause, shock index, and a ratio of pulse rate to blood pressure is more than 1. That is called cardiac index. So how do we measure blood loss? How do we approximate the blood loss? Clot size of a clenched fist is 500 ml. That is a fist. So blood loss is crossed tibia fracture is of a closed tibia fracture is 500 to 1,500 milliliters in a fracture femur. That is 500 to 200. Weighing the swab before and after use is an important method of one table assessment of the blood loss. Roughly 1 kg swab. And like the other factor, which is called lead factor, total amount of blood loss, total difference in swab width, then total difference in swab width. You can see, you can be able to calculate the amount of blood loss in that. So if the maximum capacity, like small, medium, large, is around 60 ml, 140, 350. If the blood has splitted on the floor, either 50 centimeters diameter, around 500 centimeters, 1,000, and 100 centimeters, around 0.5. And the vaginal postpartum hemorrhage limited to the bed only, that is most likely 1,000 liters. The spring from the bed to the floor is around likely to exceed 1,000 liters. So those are the way of approximating the blood loss in this type of cases. Now, calculating blood loss, you can weigh a dry swab, weigh a blood soaked swab as soon as they are scanned and subtract their dry weight. That's 1 ml of blood weighs approximately 1 gram. Subtract the weight of empty suction bottle from the filled ones. Estimate blood loss into surgical wrappers together with the pooled blood when you have the patient and onto the floor. Note the volume is of irrigation fluid. Subtract this volume from the measured blood loss to estimate the final blood loss in this patient. So the treatment is to restore the blood loss by blood transfusion, albumin, or also can give saline and hematoxylin or mixture plasma or even packed cells. You can also you have to characterize your patient, elevate the foot and monitor. You have to give oxygen support, you have to integrate, you have to ventilate in critical care. Pressure, packaging, and head down, that is what is called trend back position to stop blood pressure and blood supply to the brain. Wound exploration and proceeding, that is like the blood vessels, suturing good parts, applying pressure, all those are ways of managing it. That is the trending back position and down position for this type of patient. Then absolute rest analgesics, you can give morphine, either AFP or IM to the pain, sedation, ICT, placing the patient in hemothorax, that is laparotomy for liver or spleen or mesenteric or blood injuries, suturing and splenectomy. Fluid replacement is calculated using a 3.1 rule. Well, using a steroid for every 1 hour, ml of water, expected blood loss, topical application of local using or several boosts of activity, adrenaline, bone wax for using from bone and other local hemostatic agents like collagen membrane. In venous hemorrhagic elevation, irrigation of vein or in case of large vein structuring of venous wall, pressure and bandaging or packaging will help. Can use tourniquets, can CPD monitoring, electrolyte management, steroid injections, antibiotics, ventilator support are often required. You can also use tourniquets to stop bleeding. You can give crystalloid and coins, fluid like you can give hypotonic, you can give isotonic, you can give hypertonic, you can give coins like albumin, you can give dextran, you can give mastatin and mannitol as a fluid for various reasons. For example, they have each and every fluid have its own components depending on what you want to achieve. You use the specific fluid. So you can use various type of cannula. Cannula number 16, you can check the colors, very important. 16, 14, 18, 22, 20. The 22 is set up from pin distribution and used in pediatric or elderly patients. If you give a very small cannula, that means you need to be able to give a lot of blood in time. So the triad of death, coagulopathy, acidosis, hypothermia is subject to death in shock. Larger hemostasis agents, you can give gelatin sponge, oxidase cellulose, or collagen sponge, microfilter, collagen powder. Topical thrombin, you can do bone wax, gelatin matrices, and topical EAC or topical cyclopeptide. That is an example of absorbable gelatin sponge. Let's see. You can give artificial blood, fluorocarbon. It's a biotic substitute of synthetic oxygen carrier. It's half-life in 7 days. It is red blood cell substitute. It has got high affinity for oxygen. It is inert, colorless, odorless, dense, poorly soluble, soluble liquid. It is biocompatible. It is emulsified with albumin or piece before infusion. Its emission around injection can cause pulmonary embolism. It can bind and reduce oxygen, but as it reduces the PP oxygen, peripheral oxygen quickly, it is a disadvantage patient. They are to be kept in a hyperbaric place. Then you have the stroma-free hemoglobin. You have biomimetic hemoglobin-based substitutes. Then you have serrates, which reverse bound oxygen. Intraoperative salvage blood or on-table blood is collected, washed, filtered, and transfused used in trauma. And that is the end of this topic about shock. We have seen the shock, what is shock. We have seen various causes of shock. We have seen the pathophysiology of shock. We have seen the body, how it responds in the main organ, like the brain, the kidneys to correct it, the heart, and also we have seen the various causes and how they cause it and the various approach in this type of shock. Thank you very much for watching this topic about shock, and I think that little information you can be able to address various challenges in our workplace.